The latest clinical guidelines on the use of vitamin D for disease prevention have been made public, and I warn you that they are very controversial. They advise against measuring vitamin D and supplementing it in the vast majority of the population. Yes, you heard right. Suddenly they want you to ignore your vitamin D. Today I'm going to explain the real reason for those recommendations, my objections to them, and the personal perspective I take regarding the use of vitamin D. This information may interest you and can benefit your health. First, what is vitamin D for? A third of the world's population lives with suboptimal levels of vitamin D. And behind this reality, which we sometimes don't understand very well even from the scientific field, there are evident social changes, such as increased use of screens, indoor jobs, a more processed diet, and various chronic diseases that condition vitamin D levels. However, there are also other unknown hidden causes. That vitamin D is important is something you already know and should never forget. My relationship with this vitamin hormone is very personal, starting all in my final year of medical school, which I dedicated precisely to studying the relationship between vitamin D and cancer. Here is the study. Therefore, I cannot rule out a personal bias that always invariably leads me to pay a lot of attention to this molecule. Vitamin D is not a vitamin, we just call it that. A vitamin would be defined as a molecule that we have to ingest with our diet because our body does not synthesize it. And actually, our body does synthesize vitamin D in the skin, but it requires help from the ultraviolet B radiation from the sun. This radiation has been a daily constant until very recently in the evolutionary scale. That is, biology has assumed that we were going to receive some sun exposure daily, and therefore we were going to have vitamin D levels adequate and stable. What are the main functions of vitamin D? There are many. First, it is an epigenetic regulator. It regulates the gene expression of more than 2,000 genes through its receptor, the vitamin D receptor, which binds to our genome and controls genes regulating cell differentiation, among many other things. It has an immunomodulatory role in the immune system. Active vitamin D has a close relationship with immune cells and their proper functioning. It's no wonder it's altered in autoimmune diseases. Vitamin D is crucial for mineral and bone homeostasis regulation. Its most well-known role, discovered through severe deficiency causing rickets in children and osteomalacia in adults, is promoting intestinal calcium absorption. Vitamin D is essential for your body to absorb dietary calcium. And now, the biggest mystery of this molecule. There is a permanent, proven, and unchanging association between low levels of vitamin D and most chronic diseases that affect us. The lower the level of vitamin D, the less strength and cardiorespiratory capacity, more decline and disability. Lower vitamin D levels are associated with increased risks of autoimmune disease, cancer, especially colorectal and prostate, cardiovascular disease, obesity, metabolic diseases like diabetes, respiratory disease, and reduced athletic performance in healthy individuals. A recent meta-analysis found that vitamin D supplementation increases quadriceps strength in athletes. But here comes the first key point. Association isn't causation. Until today, after much study, we have not been able to explain why those sick people or those with health problems have low levels of vitamin D. We have not been able to reduce the risk of these diseases by giving vitamin D to people who did not have them in the first place, except for some specific cases that I will tell you about now. And we have not been able to decipher whether low levels of vitamin D lead to disease, if the disease leads to low levels of vitamin D, or if both things are true, which is what I advocate for. The only thing we know is this: low levels of vitamin D are associated with disease. That's it. Therefore, this panel of experts analyzes the latest studies on the subject and tries to answer if giving vitamin D to healthy people reduces the risk of disease. We will be seeing the recommendations they propose, some a bit controversial. The first recommendation: in children and adolescents in the age range of 1 to 18 years, empirical supplementation with vitamin D is recommended to prevent rickets and reduce the risk of respiratory diseases. Recommendation 2. In the general population without specific pathologies and under 50 years old, it is recommended not to provide more than 600 daily units, which is the recommended dietary allowance established by the Institute of Medicine of the United States. No more than 600 units. Recommendation 3 tells us that it also recommends not routinely measuring vitamin D in the analysis. Why? Because in the trials evaluated in this panel, no specific range of vitamin D has been found that can prevent disease. They also do not offer a non-routine way to measure vitamin D, for example, once every 3 or 4 years. This creates a lot of noise for me, which I'll explain later. Recommendations 4 and 5 do not suggest supplementing or routinely measuring vitamin D in the general population aged 50-74. Recommendation 6. For those with 75 years and older than 75, then they do suggest using empirical supplementation of vitamin D because they say it reduces mortality. Well, they also prefer to use low and daily doses over high and periodic doses, something I do agree with. The average dose used in this population was 900 daily units. However, recommendation 7 advises not to routinely measure vitamin D even in this older population. Recommendation 8 does recommend supplementation during pregnancy as it reduces the risk of preeclampsia, intrauterine death, preterm birth, prematurity, and neonatal mortality. The average dose in these populations was found to be 2,500 daily units, but they also do not recommend routine vitamin D testing in pregnant women. Look at recommendation 10 in adults with prediabetes. They do support supplementation as it reduces the risk of progression to type 2 diabetes. The average dose used in these trials in the prediabetic population was 3,500 units per day, a higher dose. And the last recommendation, 14, we skip the last 3 that are less interesting. In adults with obesity, they also do not recommend routinely measuring vitamin D levels or giving vitamin D empirically. We know that adults with obesity generally have lower levels of vitamin D, but its use is still not recommended in this population. In summary, they only recommend empirical vitamin D supplementation in the range from 1 year to 18 years, in pregnancy, over 75 years, and in prediabetes. It should be noted that in this case, the population that has other reasons to take vitamin D is excluded. After reading this guide and recommendation panel, I personally have many doubts. Doubts that I believe are legitimate and that I share with you today. Let's see, it's true that there is an overuse of supplemented vitamin D, sometimes without even knowing what levels we have. We think that the more vitamin D, the better, and just in case we take it. Besides, it's a cheap supplement, relatively cheap. This also occurs with many other supplements, not just vitamin D. It's also true that we measure vitamin D much more than before, and that has its economic costs. In the early 2000s, vitamin D was rarely measured, but today it is a routine test in health circles. It's true that we don't know the optimal range of vitamin D to optimize health and prevent disease. More than anything because, with a high probability, these ranges are not immovable and depend on each person, each pathology, genetics, and even latitude. However, some of the recommendations from these guidelines seem to me to be exaggerated or even counterproductive. Let's look at my objections, which are personal and merely an opinion without any greater pretension. Objection 1. They say the risk-benefit of supplementation is not clear. However, the risks of low, moderate supplementation with vitamin D are not high, far from it. Hypercalcemia at normal doses is practically non-existent, and no long-term consequences have been detected in most clinical trials. We could save some in which a slight increase in the risk of fractures has been seen, with high doses of vitamin D and intermittent doses, which are usually associated with calcium. On the other hand, the fact that we cannot exactly establish what range of vitamin D helps to prevent each pathology does not mean that these benefits do not exist. So it makes me think that the only clear benefit of ignoring the vitamin D of millions of people around the world is the economic benefit. Objection 2. On the other hand, some of the population groups in which the panel has found benefit, such as in prediabetes, are patients who often do not know they are prediabetic and spend years, if not decades, without knowing it. At least in them, the supplementation. Empirical would indeed have a clear benefit. And we're talking about millions of people, not 1 or 2. Objection 3, very important. Most clinical trials included in these guidelines include patients with adequate levels of vitamin D above 30 nanograms per milliliter. Since the potential benefit of taking vitamin D occurs in those who have low levels, if we only evaluate people who have good levels, we will not see any benefit, or the benefit will be very limited. That is, not seeing a benefit in supplementation could be because the people evaluated already had adequate levels of vitamin D to reduce that specific risk. If they are already in the target range, even if we don't know which ones, we won't see any effect. Objection 4. If benefits have been found in specific clinical circumstances such as prediabetes or pregnancy, then why with the appropriate study design are we not going to find benefit in other different circumstances? How are we going to find it if we stop measuring vitamin D in the adult population? Objection 5. The status of vitamin D and its ability to convert to its active form depends on other micronutrients like magnesium or vitamin K2, which are not usually measured or quantified in clinical trials. Supplementation with vitamin D could be harmful in a person with low intake of magnesium and K2, while it could benefit another with better nutritional status, as we saw in this video. This is not usually controlled in studies. However, many authors have been warning about this for some time. Objection 6. Many trials included in the panel evaluate supplements containing vitamin D and calcium, making it difficult to isolate the effect of vitamin D. Objection 7. In clinical trials with vitamin D, it is very difficult to control exposure to the vitamin. What do I mean? Well, unlike other supplements and drugs, sun exposure generates significant amounts of the hormone endogenously in short periods of time, in addition. So, even if we give the same dose to all participants in a clinical trial, some will invariably be exposed to more vitamin D than others, because they will take the dog out or because they will go to buy bread, unless we lock them in a room for months, which does not happen. Objection 8. Optimal levels of vitamin D probably vary by geography or population. Clearly, they differ for Norwegians and Congolese. This is difficult to address and measure in trials. Objection 9. If we don't occasionally measure vitamin D in people with normal levels, above 30 nanograms per milliliter, how are we going to detect a vitamin D deficiency in that person who previously had normal levels? Their levels drop due to various reasons, as they spend time preparing for competitive exams. The panel of experts fails to provide guidance on treating patients who already have low vitamin D levels. It is unspecified whether correction is required based on the provided information. Objection 10. The cultural changes we are experiencing are not going to reverse. Indoor jobs will continue to increase, sun exposure will continue to decrease, and our average population levels of vitamin D will continue to drop. In my opinion, this is how it will really happen. That is, there are many questions left to answer in the field of vitamin D, as you can see. Is it correct to continue measuring 25-hydroxyvitamin D that is calcidiol? Or should we instead measure calcitriol, the active form, directly? Do plasma levels reflect intracellular levels? Are there unidentified circumstances that reduce the conversion of calcidiol to calcitriol? How does the vitamin D receptor, the receptor, work in those sick people with low levels of vitamin D who find no benefit in supplementation and the conversion of calcidiol to calcitriol? Sometimes we think we're going to fix a complex system by affecting only one of the elements of that system. Another thing, the absence of evidence of causality does not mean that there is no causality, only that we have not found it. Is looking the other way and stopping measuring vitamin D in most of the population the solution? I don't think so. How are we going to get data to continue researching if we stop measuring vitamin D in the population? Measuring is the solution, in my opinion. This applies to other biomarkers too. How are we going to know if the correct supplementation prevents cancer, diabetes, or cardiovascular disease if these are diseases whose pathophysiology is gestated over many years and vitamin D trials last a few months or 1 or 2 years at most? If we don't measure vitamin D even when there's supplementation involved, how are we going to know if a patient is approaching a potentially toxic range? How are we going to detect consumption errors that are very frequent and that are only detected in the analysis? For example, a patient taking a monthly dosage of vitamin D daily, which I've seen several times. And on the other hand, associations and correlations have always been the initial engine of science. They serve to continue delving into causalities and into difficult but important questions to answer. Why do the majority of chronic patients in a wide range of diseases have low vitamin D? That would be the question that should be obsessing us and that we need to answer. Why, on the contrary, do healthy people usually have good levels of vitamin D? Reverse causality, where sick people get less sun exposure, doesn't fully explain the phenomenon. Many people who receive supplementation and even sunbathe daily on a regular basis do not raise their vitamin D levels. And many of them have a low intake of magnesium. But there are surely other reasons we do not know. How are we going to discover the reasons if we massively stop measuring vitamin D? This review from Nature in 2022 has a perspective that I think is more reasonable and concludes very simple and logical things. First, we need to correct the vitamin D deficiency in those who have it, and to do that, we need to identify it and therefore measure it. Second, the completely safe daily dose limit is around 4,000 to 5,000 units per day. And third, no clear benefits have been identified from taking high doses of vitamin D in those who already have good levels of vitamin D. In conclusion, and I repeat, this is merely a professional opinion. For now, I will continue to periodically review both my vitamin D and that of my patients. And if the levels are below 30 nanograms deciliter, I will continue to supplement to place them above that range. In certain very specific patients, I will even try to raise a little more than those 30 nanograms milliliter. In the month of less sun exposure, I will maintain a low but daily maintenance dose of about 1,000 units. This is for me, and whenever I can with common sense and without getting burned, I will try to expose myself to sunlight for a few minutes each day. I greatly respect the work done on this panel of recommendations and I think it contributes a lot, but I also believe that moving the focus away from one of the main endocrine enigmas that we have to solve is not the way forward. What do you think? I read your comments. Thank you very much for your attention. See you in the next video. A big hug and keep empowering.